Hello, good day guys and gals. I am Shania Kilisadio, a student nurse from Visayas State University, and today we're talking about neurogenic bladder. Stay tuned!
Neurogenic bladder. This is the name given to a number of urinary conditions in people who lack bladder control due to a brain, spinal cord, or nerve problem. Before we start, let us talk about the physiology of micturition. The stretch receptors of the bladder detect filling of bladder and transmit afferent signals to the spinal cord. Signals return to the bladder from spinal cord segments S2 and S3 via parasympathetic fibers in pelvic nerve. Efferent signals excite the trusor muscle. Efferent signals relax internal urethral sphincter. Urine is involuntarily voided if not inhibited by brain. For voluntary control, micturition center in pons receives signals from stretch receptors. If it is timely to urinate, pons returns signals to spinal interneurons that excite the trusor and relax internal urethral sphincter. Urine is voided. If it is untimely to urinate, signals from pons excite spinal interneurons that keep external urethral sphincter contracted. By this, urine is retained in bladder. If it is timely to urinate, signals from pons cease and external urethral sphincter relaxes. By this, urine is voided. The etiologies of neurogenic bladder are the following: diabetes, infections, accidents that cause injury to the brain or spinal cord, genetic nerve problems, birth defects that affect the spinal cord, brain or spinal cord tumors, and heavy metal poisoning. There are two types of neurogenic bladder. First is spastic bladder. Second one is flaccid bladder. Spastic or reflex bladder is a more common type of neurogenic bladder. This is caused by any spinal cord lesion above the voiding reflex arc, or the upper motor neuron lesion. This causes a loss of conscious sensation and a loss of cerebral motor control. A spastic bladder empties on reflex with minimal or no controlling influence to regulate its activity. On the other hand, flaccid bladder is caused by a lower motor neuron lesion, commonly resulting from trauma. This form of neurogenic bladder is also increasingly being recognized in patients with diabetes mellitus. Bladder continues to fill and becomes greatly distended, and overflow incontinence occurs. Bladder muscle does not contract forcefully at any time. Sensory loss may accompany a flaccid bladder. By this, the patient feels no discomfort at all. If neurogenic bladder is not treated immediately, complications may occur. The most common complication is infection resulting from urinary stasis and catheterization. The long-term complications are urolithiasis, or stones in the urinary tract, vesicoureteral reflux, and hydronephrosis, all of which can lead to destruction of the kidney. Assessment and diagnostic findings for neurogenic bladder involves measurement of fluid intake, urine output, and residual urine volume. Urinalysis, assessment of sensory awareness of bladder fullness and degree of motor control. Lastly, comprehensive urodynamic studies. The following are treatment modalities for neurogenic bladder. First is preventing overdistension of the bladder. Then, emptying the bladder regularly and completely.
maintaining urine sterility with no stone formation, maintaining adequate bladder capacity with no reflux, use of an external condom-type catheter, a diet low in calcium to prevent calculi, encouragement of mobility and ambulation, liberal fluid intake, bladder retraining program, use of a timed or habit voiding schedule. To further enhance emptying of a flaccid bladder, the patient may be taught to double void. This is after each voiding, the patient is instructed to remain on the toilet, relax for 1 to 2 minutes, and then attempt to void again, in an effort to further empty the bladder. The medical management for neurogenic bladder includes parasympathomimetic medications such as bethanical may help to increase the contraction of the detrusor muscle. Surgical management is the following. In some cases, surgery may be carried out to correct bladder neck contractures or vesico-ureteral reflux, or to perform urinary diversion procedure. The following are nursing managements. First is assessment. Assessment of drainage system for patients with indwelling catheters to ensure adequate urinary drainage. Note the color, odor, and volume of urine. Record accurate fluid intake and urine output. Patients at high risk for UTI from catheterization need to be identified and monitored carefully. They are observed for signs of UTI, which are cloudy malodorous urine, hematuria, fever, chills, anorexia, and malaise. Note drainage and excoriation in the area around the urethral orifice. Lastly, review patients' urine culture results to assess for infection. Secondly, preventing infection. Use scrupulous aseptic technique during insertion of the catheter. Use of pre-assembled, sterile, closed urinary drainage system. To prevent contamination of the closed system, never disconnect the tubing. The drainage bag must never touch the floor. The bag and collecting tubing are changed if contamination occurs, if urine flow becomes obstructed, or if tubing junctions start to leak at the connections. If the collection bag must be raised above the level of the patient's bladder, clamp the drainage tube. This prevents backflow of contaminated urine into the patient's bladder from the bag. Ensure a free flow of urine to prevent infection. Improper drainage occurs when the tubing is kinked or twisted, allowing pools of urine to collect in the tubing loops. To reduce the risk of bacterial proliferation, empty the collection bag at least every 8 hours through the drainage spout, more frequently if there is a large volume of urine. Avoid contamination of the drainage spout. A receptacle in which to empty the bag is provided for each patient. Never irrigate the catheter routinely. If the patient is prone to obstruction from clots or large amounts of sediment, use a 3-way system with continuous irrigation. Never disconnect the tubing to obtain urine samples, to irrigate the catheter, or to ambulate or transport the patient. Never leave the catheter in place longer than is necessary. Avoid routine catheter changes. The catheter is changed only to correct problems such as leakage, blockage, or incrustations. Avoid unnecessary handling or manipulation of the catheter by the patient or staff. Carry out hand hygiene before and after handling the catheter, tubing, or drainage bag. Wash the perineal area with soap and water at least twice a day. Avoid a to and fro motion of the catheter. Dry the area well, but avoid applying powder for it may irritate the perineum. Monitor the patient's voiding when the catheter is removed. The patient must void within 8 hours. If unable to void, the patient may require catheterization with a straight catheter. Obtain a urine specimen for culture at the first sign of infection. The third nursing management is minimizing trauma. Trauma to the urethra can be minimized by using an appropriate sized catheter, lubricating the catheter adequately with a water-soluble lubricant during insertion, inserting the catheter far enough into the bladder to prevent trauma to the urethral tissues when the retention balloon of the catheter is inflated. Manipulation of the catheter is the most common cause of trauma to the bladder mucosa in the patient. Infection can occur when the urine invades the damaged mucosa. Special care should be taken to ensure that any patient who is confused does not remove the catheter with the retention balloon still inflated. This could cause bleeding and considerable injury to the urethra. The fourth nursing management is retraining the bladder. Instruct the patient to drink a measured amount of fluid from 8 a.m. to 10 p.m. to avoid bladder overdistension. Offer no fluids except sips after 10 p.m. At specific times, ask the patient to void by applying pressure over the bladder, tapping the abdomen, or running water to trigger the bladder. Immediately after the voiding attempt, catheterize the patient to determine the amount of residual urine. Measure the volumes of urine voided and obtained by catheterization. Palpate the bladder at repeated intervals to assess for distension. Instruct the patient who has no voiding sensation to be alert for any signs that indicate a full bladder, such as perspiration, cold hands or feet, or feelings of anxiety. Lengthen the intervals between catheterizations as the volume of residual urine decreases. Catheterization is usually discontinued when the volume of residual urine is less than 100 milliliters. Prognosis. While neurogenic bladder can't be cured necessarily, it can most definitely be managed. Most cases of neurogenic bladder can be managed with medication and intermittent catheterization. And that's about it. Thanks for tuning in. See you again! Shania Kilisadio, a student nurse from Visayas State University. Bye!